Sure, thank you.
Should I start, sir?
Please start.
Okay. So, welcome everyone to this interesting stroke symposium. So, we thank all the speakers, panelists, and our audience members for taking time out of their busy schedule on this Sunday evening. So today we have an interesting topics to discuss. Some housekeeping issues. Dr. Deepak Arvinda sir unfortunately won't be able to join us today due to some emergency. Professor Kameshwar Prasad is currently traveling, and we hope he's able to join a little bit later. So there's a change in the schedule. We will start our program with Dr. Meenakshi Sundaram sir first, and he will deliver a talk on secondary stroke prevention. After that, we will have a panel discussion where we'll be talking about tenecteplase and its role in the Indian scenario, and then a vote of thanks. So let me just now introduce the speakers. Just a second, I'll share my screen. So this is Professor Kameshwar Prasad sir. Actually, sir needs no introduction. As I said, he'll most likely be joining a little bit later. We hope so. So, Professor Kameshwar Prasad is a Padma Shri awardee from the Government of India, and we all know him. He has had a distinguished career of more than 40 years in neurology, ex-professor in chief at the AIIMS New Delhi ECN Center, and then currently director of neurology at Fortis Hospital, Vasant Kunj. And he has contributed extensively to clinical practice, academics, and various national health leadership position. And as you can see, Sir has an vast experience in different areas of neurology, including stroke, dementia, Alzheimer's disease, epilepsy, so on and so forth. And Sir is actually a pioneer in evidence-based healthcare in India and has contributed to many Government of India programs since 1997. And I know, Sir, from many years, he had trained at McMaster University. In fact, one of my alma maters also. And McMaster University actually known for these epidemiological studies, Dr. Salim Yusuf and others. You may have read some of his papers. And Sir has trained there, and he is the founding president of the Indian Stroke Society, member of various WHO strategic and technical advisory groups, expert member of multiple sclerosis international federation, meningitis guidelines, and many others. And as I said, has been the recipient of Padma Shri and recognized widely across the world for stroke care, neurological research, and global health collaborations. Next, we have Professor Mendirata sir. Just like Professor Kameshwar Prasad, Professor Mendirata sir, is an inspiration for all of us. He has been a student neurologist for vast experience and has served across many institutions across India. Now, sir is currently the principal director and senior consultant at Department of Neurology at Dr. B.L. Kapoor Hospital, Max Healthcare. Sir was a former director professor at GB Pant Hospital, Delhi University, and an ex-director professor and HOD at Janakpuri Super Speciality Hospital. And Sir has vast experience in many areas of neurology, including stroke, epilepsy, neurosonology, and comprehensive neurological care. And Sir, has been recognized as an expert in advanced stroke management. And as you can see here, Sir has close to 800 publications. And let me tell you, those of us who publish, how difficult it is to publish in Lancet Neurology and Stroke. So, just for stroke, some of the members, acceptance rate is 7%. So, Sir has a vast experience, published huge number of articles, author of 60 plus book chapters, and contributed to high impact neurological research from India. Sir has been the past president of Indian Stroke Association and Asia Pacific Stroke Organization and Indian Society of Neurosonology, board of director at WSO and editor in chief at International Journal of Epilepsy. And Sir is the author of the book Puzzling Cases in Stroke and contributed to various postgraduate institutional programs across country. Welcome, sir. And then we have Dr. S. Meenakshi Sundaram, who I have known for more than a decade, and sir has been a champion of stroke care in India. Sir is presently a senior consultant, a neurologist at Apollo Specialty Hospital, Madurai. And sir is a gold medalist from awarded as DM Neurology from NIMHANS, Bangalore. And sir has specialization in stroke management, epilepsy, movement disorder, neurorehabilitation, advanced stroke interventions. And I think one thing I can tell is I remember, sir will tell you more about it. Way back in, I think in 2008 or 9, sir had used actually intra-arterial tenecteplase way back then. And, it was a case study published. So you can see sometimes, our own, our faculty here are way advanced than people outside India. So this is sir's contribution. You can see extensive publication record and also contributed to many neurological textbooks across India, including practical neurology, localization of clinical neurology, DeLong's neurological examination. So welcome, sir. So I will stop here and I will first invite Dr. S. Meenakshi Sundaram sir to deliver his talk on stroke prevention. Thank you, sir.
So you're not audible right now.
Meenakshi, you are muted.
Is my slide visible now, ma'am?
Yes, sir.
Yes, sir.
Full screen. Yes.
Yeah. Can I start, sir? With your permission? Can I start, sir? Hello?
Yes, sir. Yes, sir. You can start, sir.
Yeah. Thank you. Thank you. Welcome to this presentation on secondary prevention.
Absolutely. Please.
Thank you, sir.
Yeah, I was muted. Yeah. Thank you.
Secondary prevention and acute ischemic stroke will be the discussion for today. I bring greetings to you from the temple city of Madurai. My pranams to my teachers. And I have certain declarations, some warnings and confessions to make. My entire presentation is based on a single case of stroke only, my own case. It's a real scenario. It's only a garden variety of stroke, an atherothrombotic stroke. That will be the only presentation. And with the constraints of time, I will not be able to discuss about cardioembolism or other types of strokes. They are not covered because time will not permit that. And whatever information I use in my practice, I present. I'm not going to present some hi-fi stuff like grade 1A recommendation, grade 2B, AHA guidelines, ASA guidelines, ISO, ESO. No, none of these guidelines will be presented. And I am proud to say I'm a GP in neurology and a happy, proud GP I am. I want to practice only as a general practitioner of neurology. So before I start my talk, I have a dozen questions as quoted my teacher. He says, you always come with a dozen questions. So there are a dozen questions, all MCQs. And you have to just answer the answers as 1A, 2B, and so on and so forth. Kindly post the answers in the chat box directed to Kalpita Madam, marketing team of NQ, who is the host of this event. And it will be guided by our professor, Dr. Mendiratha sir. The answers will be collated by Kalpita Madam, and maybe she will give a winner the token prize, maybe a grand one that she will decide. Madam, is that okay with you?
Yes, sir. Yes, sir. Surely.
Thank you, ma'am. So I'll take you through this case winner. This is a 56-year-old gentleman. He is a businessman who was treated at a private hospital 4 months ago for left MCA therapy ischemic stroke. He has now completely recovered. He seeks second opinion for optimizing medical care. He has comorbid hypertension and diabetes. Now, after the stroke, he has reduced his amount of smoking. He has completely quit alcohol. But wife says he continues to be a very stressful personality. Clinical examination, his blood pressure 150 upon 90, heart rate 64 per minute. He has a left carotid bruit, weight 92 kg, height 168 centimeters. Cardio and neurological examination, clinically normal. At the time of evaluation in my outpatient clinic, his NIHSS was 0. He was on the following medications when he came to me: 75 mg of aspirin and clopidogrel each, rosuvastatin 10 mg. This was a pill which had all the 3 components. He was also on metoprolol 25 mg once daily and nifedipine 10 mg twice daily. He was on sitagliptin dash metformin combination. He was on multiple vitamins and neuroprotectives. Investigations had been done at the time of stroke, MRI and blood workup. And this was the investigations he got it done before he came to me. Now this shows perfect investigations, and to have a gist of this, what is abnormal here is the HbA1c level of 9.3%. His total cholesterol was 188, his LDL was 92, triglycerides 287, and the homocysteine levels were significantly elevated. Normal being 16, he had a level of 49. So these were the abnormalities that was glaring when he came to me. So these were the investigations done at the time of stroke. MRI brain and MR angiogram had been done. Old stroke, it was an ICAT which he had, intracranial atherosclerotic disease. He had undergone ECG that was unremarkable, and had also undergone a transthoracic echocardiogram. Ejection fraction 62% with impaired LV diastolic function and concentric left ventricular hypertrophy. And just before coming to me, he had got these investigations done: normal hepatorenal functions, electrolytes, and hemogram. As I mentioned, these were the levels of sugar, HbA1c, lipids, and homocysteine level. In addition, vitamin D was low and vitamin B12 levels were normal. Now, here is the first question for the pre-test. If you look at the presentation, the current anti-thrombotic strategy in this patient that he was taking at the time of this presentation was aspirin and clopidogrel. What should be the best strategy now? Do we continue the medications as such because he has multiple risk factors? That is, he has ICAT, hypertension, diabetes, he is obese, he still smokes, he's a stressed person. We should reassess him after addressing these risk factors after 3 months. Choice B, switch him to aspirin alone or to clopidogrel alone, or change clopidogrel to prasugrel or ticagrelor because echocardiogram is reported to show some abnormalities. As I mentioned, I request the audience to just give an answer. All you have to write is 1A or 1B or whatever answer you feel into the chat box, specifically of Kalpita madam, whom you can see in that chat box. You can directly write to her, not in the general group, because others should not be disturbed by that. I'll take you to the second question. Dual antiplatelet therapy instead of single antiplatelet therapy must be used in which of the following situations? Low risk TAA and minor strokes, low risk TAA and severe strokes, high risk TAA and minor strokes, high risk TAA and severe strokes. I'll pause for a couple of seconds before I go to
Sir,
the question
I
number 3.
just, sorry to interrupt. I just want to say that they can answer in the chat box directly. The individual responses won't be visible to anybody else. So they do not need to direct it to me specifically. They can answer directly.
Sure, ma'am. Thank you very much. That's a clarification you have given. So answers could be given. That's the second question. And then the third question, the similar vein, the maximal duration of dual antiplatelet therapy a patient with stroke without any other vascular comorbidity should receive is 3 weeks, 3 months, 2 years, indefinite. And the fourth question is, in this patient, what should be the target of...
Meenakshi, go slightly slow. Let the slide hang for at least 10 to 15 seconds. Yes.
Yes. Shall I go to the next question, ma'am? I'll go.
I think there's sufficient time. Yeah, now go.
What is the BP target in this patient? Less than 140 upon 90, 130 80, 120 70, 110 70. Question 5. If you decided that his presentation BP 150 is upon 90 is high, what antihypertensive you would choose? ABC, is it AC inhibitor or an ARB also you can use that, or is it a beta blocker? Is it a calcium channel blocker or any of the above? What would you choose among these three? AC inhibitor, beta blocker, calcium channel blocker, or anything is okay. Question number 6 would be, this is interesting. His brother told me that he also wants to know if he should be on any antihypertensive drugs to prevent stroke. So I checked his BP and found that it was also around 150/90. He did not have stroke at all. So what antihypertensive is best suitable for this brother of this patient? Again, same choices: AC inhibitor, beta blocker, calcium channel blocker, or you say none of the above. Only non-pharmacological therapy is enough. Question 7. Which of the following GLP-1 based therapy is dual acting? That is, it acts on both GLP-1 and GIP receptor agonists. Because these are now into the market, and one of which came out of patent a couple of days ago: semaglutide, dulaglutide, exenatide, tirzepatide. Shall I go to the next one, madam?
So maybe should
Yes,
we
sir.
wait
Yes,
for
sir.
few seconds? You are getting any responses?
Yes, sir. Yes, sir. We are getting responses.
You could just tell me next slide and I will go, madam, after a few responses.
Yes, sir. You can go ahead to the next slide.
Next one, yeah. Which of the following lipid lowering strategies has been proved to be beneficial in the secondary prevention and of stroke as well as prevention of other cardiovascular events? Diet, fibrates, statin, all the above.
I think you can go to the next one.
What is the lipid target of treatment in this patient whom I have given? LDL less than 120, triglycerides less than 200, or LDL less than 100 but triglycerides less than 200, LDL 80, triglycerides 150, LDL 70, triglycerides 150.
Yes, sir. We can go to the next one.
Which one of the following medications is technically not a PCSK9 inhibitor? Is it inclisiran, evolocumab, alirocumab, or lerociclib?
Yes, sir. We can go to the next one.
Which one of the following factors is not part of the cluster of factors contributing to the term metabolic syndrome? Diabetes, hypertension, low HDL, elevated triglycerides, abdominal obesity.
We can go to the next.
And the last question, considering the elevated homocysteine level in this patient, which of the following supplementation will be most useful in reducing the risk of recurrent cardiovascular disease or stroke? B12, folic acid, both, none. So I'll stop here and we'll go to the discussion part. I request Kalpita madam to go through the answers and let me know the winner as I complete the talk.
Sure,
So
sir.
all these 12 questions were in context of the single case scenario which I presented. At the outset, my sincere thanks to Professor Dr. Manmohan Mendiratta sir. We all know he is one of the most inspiring neurological figures in our country, and I've been fortunate to be patted by him on a few occasions. Thank you, sir, for your constant encouragement. I also thank Professor Dr.
Thank
Kameshwar
you so
Pradar
much.
sir and Dr. Deepak Arjundar sir, whom we could not get him today to moderate this session. MQ Pharmaceuticals, thank you very much for providing me with this platform. My temple, Apollo Hospitals, and Goddess Meenakshi, the Supremo of Madurai. So incidence of stroke in India is 119 to 145 per 100,000 annually. Approximately 20 to 25% of strokes occur in patients who had previous stroke or TIA. And that's the relevance of this present talk. A significant proportion of strokes occur in individuals less than 65 years. That means you have got a large chunk of young people developing stroke, 20 to 30% occurring in less than 50 years. And more than 90% of the stroke burden can be traced to modifiable risk factors, which is why we should be aware of what we should do for a given patient. So this was the case vignette which I presented. I'm not going to read this completely. We all saw this, and these were the investigations I presented. So what do you have here? He is a 55-year-old gentleman, recent ischemic stroke. Hypertensive, diabetic, obese, stressed person, now trying to adopt some healthy lifestyles. And this is the ideal scenario for us to consider secondary prevention strategies. So this was the first question. What should be the anti-thrombotic strategy? Let us see this. The key points here are that he is on dual antiplatelet therapy when he consults us, and the stroke happened 4 months ago. This is a very common scenario we all see in our practice. So when should you give dual antiplatelet therapy? That was question number 2. And how long we should give dual antiplatelet therapy? That was question number 3. Now here are the recommendations. This is 2026 guidelines for the management of stroke. When you look at that, short-term dual antiplatelet therapy is used in patients who have got low NIHSS score, by which we say less than or equal to 5, which means they qualify for the minor ischemic strokes, because anything beyond that, the incidence of hemorrhage will outweigh the benefits which you would get by using dual antiplatelet therapy. In a patient who has got an intracranial large artery atherosclerosis, ICAT, as in this patient, when the stenosis is 70 to 99%, there is no good data to say we can intervene in these patients. Rather, this is a candidate for dual antiplatelets. And then again, if a person has got high risk TA, by which we say the ABCD square score is at least 4, then you need to give dual antiplatelet. We do not use it in low risk TA, again, because for a low risk patients, dual antiplatelet therapy associated risk of hemorrhage will outweigh the benefit which we will get. And how long to give? These are data from the POINT trial, CHANCE trial, and the THALS data. 3 weeks for high-risk TA and minor ischemic strokes, and for large intracranial artery thrombosis, ICAT, used for 3 months. That was the data we got from SAMPRIDGE trial. And beyond this, is it useful? The answer is no. MATCH trial and Charisma trial showed us that it is actually harmful to continue dual antiplatelet therapy beyond 3 months. Therefore, what is the antithrombotic strategy we should employ for the non-cardioembolic ischemic stroke or TIA of atherothrombotic lacunar or cryptogenic stroke? Use a single antiplatelet. You could choose either aspirin or clopidogrel or aspirin extended release dipyridamole combination. So dual antiplatelet therapy, question number 2 is choice C, use only in high risk TA and minor strokes, and the maximum duration, whatever you do, cannot exceed 3 months. What are the antiplatelets which have been used in stroke? In addition to aspirin and clopidogrel, they include aspirin plus extended release dipyridamole, as was shown by ESPS2 data and ESPRIT data, followed by PROFESS data, which showed we could use this combination. And then ticagrelor, for a short time it could be used, as was shown in Socrates trial, where it was shown that when the patient has got ipsilateral atherosclerotic stenosis of an extracranial or an intracranial artery, including less than 50% stenosis, or if a patient has got a mobile thrombus or a thin plaque in the aortic arch, you could use ticagrelor plus aspirin, or you can use this dual combination therapy. Therefore, however, this is to be used in acute setting. In our patient, it is a late secondary prevention beyond 3 months, and therefore, ticagrelor is not suitable in our patient. What is the other drug? Prasugrel. The Triton TMA 38 data showed that if a patient has got a past history of stroke, do not use prasugrel because there is a high chance the patient can develop hemorrhage. There are two other molecules, the cilostazol, which was studied in the CASIS data and the CSPS data from China and Japan. They use it a lot there. We also have it in our market, though it's not popular in India. And then we have ticlopidine and trifluzel, which has questionable value. Ticlopidine was available, but now it has gone out of our favor. Is clopidogrel superior to aspirin? Probably yes. That was the KT data, clopidogrel versus aspirin in the prevention of recurrent ischemic events. Aspirin 325 mg versus clopidogrel 75 mg. Clopidogrel was probably superior. But the caveat was that the benefit was predominantly driven by peripheral vascular disease. Another point we need to remember is the possibility of clopidogrel resistance. Whether it is really relevant in our data, we do not know, but we still need to keep in our mind. So the possible answer to question number 1 is that we could switch to clopidogrel alone, although switching to aspirin alone also should be a correct answer. But considering the Capri data, maybe clopidogrel alone could be a good choice, because in our country, the cost difference between aspirin and clopidogrel is not too high, and therefore we could opt for clopidogrel. The next issue is, this patient has got a blood pressure of 150 upon 90. The question to address is this good enough? Some people tell, sir, I am used to this blood pressure. Let us see the data on this. What should be the target blood pressure in this given patient? And then if you decide that BP is high, what drug we should use? And if a patient did not have stroke in the past, what drug should be used for this given patient? Antihypertensive therapy is important for both prevention of recurrent stroke and prevention of other vascular events. Blood pressure could be reduced by various lifestyle modifications, we all know that. And in the setting of acute ischemic stroke, in the first hours or days after the onset, we do not allow the blood pressure to fall too much. We call it as permissive hypertension. There are patients who have classified as high risk group where the target blood pressure should be less than 130/80, if possible even less than 120/80. Who are they? Patients who have known atherosclerotic cerebrovascular disease, heart failure patients, diabetic patients, chronic kidney disease, elderly people, and those where we have calculated the 10-year ACVD even more than 10%. Our patient has diabetes, at least in this category, and therefore he definitely is a high risk patient. What is the strategy in patients who have a history of stroke or TIA? What is the take on antihypertensive in these patients? In any type of stroke and BP more than 140 upon 90, you start a medication. This recommendation is grade 1A. In an atherothrombotic stroke or a lacunar stroke or a cryptogenic stroke, and the BP is more than 120/70, start the medication. This is grade 2Z recommendation. And in a cardioembolic stroke, example, atrial fibrillation associated stroke, if the blood BP is less than 130 upon 80, do not start. And in any patient, if the BP is less than 120/70, don't start. These are rough guidelines we could use in our practice. AC inhibitors with or without diuretics are the agents which are best studied for secondary prevention of stroke, as was shown by progress data and hope data. Whereas for primary prevention of stroke, calcium channel blockers have the best evidence. And beta blockers have no stroke benefits. When we use these data, question number 4, what is the BP target? The answer is less than 130 upon 80. And question number 5, if the BP is high in this given patient, the best is to use ACE inhibitor, which could be perindopril with or without diuretic, like indapamide, that was used in progress data. The brother of this patient, best treated with a calcium channel blocker, say amlodipine. Back to our case, preferable to add perindopril plus indapamide. We have also the option of stopping metoprolol because this patient's heart rate was only 64 per minute. It's an option we could consider and carefully follow the patient. The next issue in this patient is his diabetes. When you look at that, HbA1c is significantly elevated in this given patient. Diabetics have twice the risk of ischemic stroke, and the risk factors which promote carotid atherosclerosis in diabetics include dyslipidemia, endothelial dysfunction, and platelet and coagulation abnormalities. Even patients who have got IGT, they have higher risk of ischemic stroke when they have previously had a TAA or a minor ischemic stroke, and also for carotid atherosclerosis. The recommendations are to get the HbA1c less than 7% by use of diet, exercise, oral hypoglycemic agents, and insulin. And today, there are newer therapies which have also got some stroke data, the GLP-1 based therapies. These are newer drugs in the horizon. Exenatide was used in the TEXA-IS study. The caveat is that despite the common sense knowledge that less than 7% HbA1c should give a great benefit, as of now, evidence has not shown a consistent beneficial effect of intensive glucose lowering therapy for the macrovascular outcomes, as was seen in the recent SHINE trial. Now, we also have to be aware of these newer agents which have now been loaded into the market. We have GLP-1 based therapies. There are two sets of drugs. One is the one which acts only on GLP-1, and then the dual agonist. So the question number 7 focused on which one of this is a dual agonist, and the answer to that is tirzepatide, which has hit the market now. The Mounjaro has come to stay with us. Dual acting drug. The other drugs are single acting, that is only on GLP-1 agonist. They are semaglutide has now come out of patent. It's going to be cheap. It's going to be available all over. We have other agents as well. Suggested recommendation in this patient, of course, should be target HbA1c less than 7, give him a good dietary plan, let him consult a physician or a diabetologist who could look into this more carefully and could give better advice than us neurologists. And he could also consider a GLP-1 based therapy because he is a high risk patient, he has got poorly controlled diabetes, and he is obese. So these things should be targeted in these patients. Now coming to the next target, the cholesterol. If you look at that, the LDL was quite high, 92, triglycerides was high. So what did we do for him? And that was the idea of putting this question number 8. Which of the following lipid lowering strategies is beneficial in the secondary prevention of stroke? And the common sense answer should be all the above. Let me dwell upon this. Cholesterol is an established risk factor for atherosclerosis. However, the link between cholesterol and stroke per se is not very high. The risk varies for various subtypes. There is a weak yet a positive association with large artery atherosclerosis and lacunar strokes. We all know increased cholesterol and LDL is associated with increased ischemic stroke risk. Cholesterol with carotid atherosclerosis, there is a strong association. And we have been taught from the Framingham data that there is an inverse association between cholesterol and hemorrhagic stroke, by which we say very low cholesterol is associated with hemorrhagic stroke. The surprise but the factual information is that all lipid lowering methods with diet, with fibrates, with niacin, with bile acid sequestrants, they do not have any significant impact on the secondary prevention of stroke, or for that matter, the prevention of any other cardiovascular events. It is only statin. And that was the idea of putting across this question number 8. The answer is only statin. And now we know It is because not just the lower cholesterol levels we achieve with statin, it's because of the pleiotropic effects, the anti-atherothrombotic, anti-inflammatory properties of statin. And this is seen even in patients who have got average cholesterol, as was shown in the Sparkle data and the HPS data. Lower the LDL, lower was the risk of major cardiovascular events, including the initial stroke and the recurrent stroke. Point that was regardless of the age, the gender, the pre-treatment blood lipid concentration, and the greatest benefit was achieved with 80 mg of atorvastatin or simvastatin 40 mg. It's not popular simvastatin. We predominantly use rosuvastatin 40 mg, as was shown in the BMC meta-analysis. We need to monitor this patient. Fasting lipids should be done after 4 to 12 weeks and then should be monitored at least 3 to 12 monthly. So what is the lipid target in this patient? The answer is lower the LDL cholesterol, greater is the benefit. That was what was shown in the treat stroke to target trial, the TST trial, where the target of less than 70 gave the best benefit. In this given patient, if we cannot achieve the target by statin alone, what we need to do is to add other medications. Ezetimibe and PCSK inhibitors are the answers to that question. So what is the lipid target? The answer is less than 70 LDL, less than 150 triglycerides. And this was a trick question. Which one of the following medications is technically, I mentioned, not a PCSK9 inhibitor? And the answer is it is inclisiran, because it is a small interfering RNA that lowers LDL by silencing the PCSK9 gene in the liver, whereas others directly inhibit the PCSK9 straight away. How do you manage triglycerides? By lifestyle modification, treating hypertension, achieving glycemic control, and all LDL lowering therapies also bring about a reduction in triglyceride levels in those patients where despite all these things, we are not able to do it. You could add omega-3 fatty acids, icosapent ethyl, 2 grams twice daily. Remember, these are expensive drugs and should be used only in a select few patients. Back to the case. This patient increased rosuvastatin to 40 mg, or you could also use 20 mg and follow up. I increased the patient to 40 mg dosages. The next concern in this patient is his obesity. 92 kg, 168 centimeters means a BMI of 32.6. Obesity is associated with increased cardiovascular disease, including ischemic stroke. However, like diabetes, the data does not show the weight reduction to be consistently associated with reduction of recurrent stroke risk. However, decreased weight potentially is beneficial for improved control of all other important parameters like blood pressure, sugar, and lipid levels. Therefore, it is reasonable to address obesity. And of course, physical inactivity should also be addressed, especially in such high-profile businessmen, because low physical activity and prolonged sitting is associated with the increased risk of cardiovascular disease, including stroke. The recommendations are to achieve a moderate intensity exercise of minimum 10 minutes for at least 4 days a week, or vigorous intensity exercise minimum 20 minutes for at least 2 times a week. So the question is, what is this moderate intensity exercise? It should be an activity sufficient to break a sweat, or noticeably the patient should feel tachycardia by walking briskly or using an exercise bicycle. Every patient, whether you treat common cold or COVID or cancer or a cardiovascular disease, they are going to ask this question, doctor, what diet my husband should be given or what diet I should take? So the answer to that question is a Mediterranean diet, which should be 50% fruits and non-starchy vegetables, 25% mainly from plants, and 25% from carbohydrates, which could consume a lot of vegetables and fruits and whole grains, limiting sweets, sugar sweetened beverages, and red meat. The calories from saturated fat should be less than 5 to 6%. The calories from trans fat should be restricted, and the sodium intake should be restricted. Our patient, the thought is, does he have metabolic syndrome? The idea is to just give a concept of metabolic syndrome. The answer to this is that metabolic syndrome consists of 3 of the following at least: high fasting glucose, hypertension, low serum HDL, elevated triglycerides, and abdominal obesity. It is a pre-diabetic condition. It's unclear whether metabolic syndrome is an independent risk factor for ischemic stroke beyond the sum of its components, or it is just a contribution plus all these components. That is all. However, it is important to treat the underlying causes like physical inactivity and obesity. So the answer to this question is he is already a diabetic, therefore we cannot technically call him as metabolic syndrome. That should be reserved for somebody who is yet to develop diabetes. And do we do something about this? Can we treat patients with metabolic syndrome because that is associated with insulin resistance? There is a good data on pioglitazone, which is known to reduce the risk of recurrent stroke and myocardial infarction, even in non-diabetic people who have insulin resistance. However, we need to keep adverse effects in our mind, which is bone fracture, heart failure, and weight gain. This is the multi-center high-risk data which showed benefits with the pioglitazone, but the NNT was 36 and NNH, that is number needed to harm, was 53 for bone fracture. Could be considered as select patients. The next thing to address in our patient is the issue of smoking and ethanol use. Smoking is a risk factor for all stroke subtypes, and there's a strong dose-response relationship. Both ischemic stroke and subarachnoid hemorrhage are predisposed by smoking. The patient should be told that he has to completely quit smoking, not stopping the act of smoking. Patients tell me, sir, I want to give step by step. I tell them, go to the third floor of building, come step by step down, and you got to quit the smoking. As simple as that. And it should be warned that the increased risk of stroke due to smoking does not vanish. It is completely eliminated by about 5 years. Alcohol, it's a controversial subject. Does decrease of alcohol intake decrease recurrent stroke risk? There is no clear evidence from clinical trials. Probably light drinking is associated with decreased risk of ischemic stroke, and heavy drink is associated with increased risk, but I do not know how to interpret this data. Not relevant, but for completion's sake, substance abuse, IV drug abuse, stimulant use are all going to increase the stroke risk. An important modifiable risk factor for stroke is obstructive sleep apnea. Think of this in every obese patient, as in this case. Always go at the sleep study, carefully take history, because treatment with CPAP and behavioral modification therapies are going to give a lot of benefits. So the last question in this presentation was about the homocysteine levels, how good they are. Homocysteine elevation is associated with increased coronary and cerebrovascular disease. It is going to increase the risk of large artery subtype of ischemic stroke and possibly also small artery subtype. But there is a catch there. Despite this, homocysteine reducing vitamins have not shown any benefit in the secondary prevention of cardiovascular disease or stroke. Therefore, it may not be beneficial to routinely screen patients for homocysteine level or any other vitamin levels for that matter. Supplements like vitamin E, beta carotene, vitamin C, they have not shown any great benefits by using these antioxidant vitamins. So the answer to this question is that though it is not going with the reasoning which we have, the answer is still none. The secondary prevention of stroke addresses several modifiable risk factors which I have just discussed and I have listed here. And there are, of course, non-modifiable risk factors which I'm not going to dwell. A glimpse at this slide is good enough. Bird's eye view of other issues will include cardioembolic strokes, the non-valvular AF, where we go for long-term anticoagulations, direct oral anticoagulants or warfarin. And then there are other potential cardiac sources of embolism where anticoagulation therapy may be indicated, just as the number of cases which I have listed. For want of time, again, to stick on to my time schedule, just a glimpse in this slide is good enough. And then we have the PFO. We use the Pascal and the Rope scores. And then we go for device closure in a young person who shows abnormality on a right to left stent on bubble study in a patient who has the so-called cryptogenic non-lacunar embolic appearing stroke and where antiplatelet has failed and there is an associated atrial septum. Otherwise, in elderly people, it is always antiplatelets. Surgical closure could be done if the heart is open for any other reason. There are miscellaneous hypercoagulable states which I have mentioned. And there are stroke-specific secondary prevention guidelines which will include several of the conditions which have been mentioned here. For want of time, I wouldn't touch that. There are several causes. Each of them will require tailored antiplatelet or anticoagulant strategies. I stop here. Thank you very much for the opportunity, and the allied panel will take the questions from now on. Thank you once again, sir.
Thank you so much, Dr. Meenakshi Sundaram. It was wonderful talk and very impactful, very practical, bedside talk. So you touched upon almost all the risk factors of the stroke and how these should be handled in day-to-day life. There are few points which I also noticed from your case was that vitamin B12 level was normal, still homocysteine was raised. So we'll have to also to do MTHFR gene study in this patient, number one. Number two, what I also observed, you mentioned about carotid bruit, but in the talk not mentioned about CT angiograph or MR angiogram if the kidney failure is there. So those things also, is it LVO, that large vessel occlusion, hopefully, because carotid bruit is there, so there is significant narrowing. So those points should also be touched upon this case. And I hope if has Commissioner joined or not? Professor
No, sir, not yet. I think he has not yet landed.
No problem. But Dr. Meenakshi has beautifully highlighted most of the points. So if there are any questions, we can take up. Dr. Meenakshi can also answer, and I'll also be happy to answer the questions which are related to this talk or related to tenecteplase. Thank you.
Sir, to answer one of your questions, sir, MR angiogram was done, which I had presented in my slides, sir. I offered CT angiogram for this patient, but the patient did not want to undergo that. He said, I'm comfortable now. With the reason he asked me why you want to do it, I told him that if it is a significant block, we would go ahead and do some interventions, cardiac interventions. He said, sir, I'm comfortable now. I don't want to go through this. And MR angiogram, we stopped there, sir. It was done before he met me.
Why I'm saying is that
yes, sir.
One is if there is a symptomatic stenosis, one intervention on the ipsilateral side, and if there is a asymptomatic significant stenosis on the other side, as per the CREST-2 study, should also be taken care.
Yes, sir.
So another second was about the homocysteine and MTHFR, while vitamin B12 being normal, maybe patient was loaded with vitamin B12 injections outside, then B12 can be normal, but still homocysteine can be high, and he may have MTHFR gene defect, which can lead to hyperhomocysteinemia. And once also we presented a poster in American Academy of Neurology. Is hyperhomocysteinemia is a true risk factor or not? So, yeah, thank you. I think MTHFR you can get it done. So, though this was persisting even after 4 months. If in acute phase homocysteine is high, we need to repeat after 3 months. So, like we say, antiphospholipid also after 3 months. Not only IgM and IgG, but also DRVVT. Those should be carefully looked into.
In the audience, sir, probably I'd invited Professor Dr. Chidambaram Yegappan, Stroke Chair, McMaster University. I'm not sure whether he has joined really. In case he is there, you can take your views if it is okay with you, madam. He'll be in the audience link.
Yes, sir, he has joined. He has in fact mentioned.
He has taught us so many things.
He will be a respected panelist, I will say. Honorable panelist, yeah.
Thank you, sir. Because he used to come to our place and teach us. He's from our place, sir.
Wonderful.
He's one of the persons who inspired us for teaching. He's a phenomenal teacher, sir. Yesterday he taught us.
Excellent, excellent.
Can you ask sir to comment, Professor Chidambaram to comment if Kalpita, can you just...
Yes, sir, he has actually mentioned in the chat that it was a good evidence-based presentation. He has just commented and shared his view in the chat box.
So is it possible for him to, comment?
I do not know. He
The
yesterday he
video?
presented to us, sir. He taught us yesterday.
If he
But I
has,
recall.
like, if he has joined, he can switch on his video,
Video, if
and
you
it
can.
will be beneficial to the attendees, his presence and his vast knowledge.
Sir, in that case, I think Dr. Meenakshi, can you just share the faculty link with him, because he won't have the access to open the
I will
camera
share
via
with him,
the
ma'am.
delegate.
I'll share, madam. I'll share. In a minute, I will share. If you can just send the faculty link to me once again, I will. It is there. Okay, I'll share. I'll share. Got
I
it.
will send to you if you need it.
I'll send.
So meanwhile, we also have another question from Dr. Sanjay Mishra. He has asked that if a patient has protein S deficiency, how long to continue anticoagulant treatment for secondary prevention of stroke?
Meenakshi, will you like to answer?
That you can answer, sir. When you are there, why me?
Because this is a thrombophilia, and this is a genetic defect, and the anticoagulant has to be on lifelong, with due precaution of taking care of we use in these cases still vitamin K antagonist, and it may have to be used lifelong. If it is a definitive relationship, then lifelong. Yeah. Protein C, protein S, Leiden factor, or antiphospholipid antibodies, cause and effect relationship, then probably lifelong. And especially if you find arterial stroke and venous stroke, you can read our 10 cases I reported on antiphospholipid antibodies syndrome and stroke in young. So if this is present and they can have arterial and venous stroke both, so then you should suspect EPLA. And if EPLA is there, then again the anticoagulants are lifelong.
I have a doubt to ask, sir. How common is arterial stroke with the protein S or protein C deficiency, sir?
Sir, I won't have the epidemiological data. It is a rare disease. It's a rare disease. And especially in stroke in young, in our study, when you 127 subjects I reported out of 940 registered from my hospital. So thrombophilia was present in 2 cases, but that was antiphospholipid antibody syndrome. Protein C, protein S, occasionally we see a case. I will not say it's quite uncommon, it's rare, but in where you don't find any other cause, you have to look for other causes of thrombophilia. This is one of them. Yeah.
I think Dr. Chidambaram has not joined yet.
I'll try to look that. Dr. Yegappa. And again, one thing. Sir, you can join Manila, sir. But you can join as a delegate link. I've informed him, madam. He will join shortly.
Sure, sir.
I purposefully left out the cardioembolism part of it because they gave only 20 minutes for the entire presentation, sir. It was already 25 minutes, which I have done because of the questions.
The other
So, that would be
thing
wrong.
which you presented for the audience about the PFO,
Yes, sir.
Rope score is a good score we use, but once you are above 60, you almost disqualified. But
Yes, sir.
Pascal classification is very important, especially if you have say right to left shunt with the bubbles being there, number of hits like high intensity transit signals or bird chirping, and then you also have in addition a atrial
Yeah,
septal
I'm here.
aneurysm. It can be. Thank you so much, sir, for joining. So
Yeah,
that can be very
I'm
helpful
seeing
to
that.
decide about intervention in PFO, which can. Thank you, sir. Thank you, sir. Intervention in PFO, particularly with whatever the device you use, and I'm using quite frequently in my institute. Yeah.
Thank you, sir.
Please, yeah, carry on.
Thank you very much for asking me to join the panel. Are you hearing it? Can you hear?
Yeah, very clear, very clear, sir.
And I have seen your book, sir. You have written a book on evidence-based statistics from McMaster. Am I right?
That's Kameshwar Prasad.
Oh,
Kameshwar has written.
Yeah, I've seen the book there.
Yeah, Kameshwar has written. Yes.
Yeah.
Yes.
I have written on puzzling cases in stroke, two volumes, and now third edition would be coming. Yeah.
Okay. Yeah. We have Professor
Right to left side with number of hits.
Can you hear that?
There is background sound coming.
1 second.
I think maybe the television is on or something. There's another sound coming on the background.
Okay, now the echo should go away now. Yes.
Yes.
We have in our faculty a couple of people who are internationally worked with a lot of people, and I have been with the Canadian Stroke Consortium. I was in the panel with Dr. Mehta, and also he is retired now. We have Dr. Oskowski, who's also retired now. And so we have a lot of people now. In the last 10 years, we have increased our stroke research. We have formed a separate department at McMaster. Now, coming to Dr. SMS presentation, excellent evidence-based presentation. In each and everything, he pointed out to the research papers which have come, which are all pivotal trials he has been mentioning, which is excellent. I have one question only regarding it, because I don't know about the Indian population, what you guys do. If a patient is not tolerating statin, what drugs do you give? Is it the injection form, which is PCSK, or is it something else? Because as you said, the others don't have any benefit on stroke.
Yeah, Meenakshi, you can answer.
Thank you, sir. Sir, if the statin intolerance is there, we should really check whether it is true intolerance. For example, all doctors are intolerant of statin. They'll always say we had muscle pains. Once you know that, the patient will come with the side effects. If it is a true intolerance, then we have to give the maximally tolerated dose. That's the next strategy. Reduce the dose to atorvastatin, say 10 to 20 milligrams, or rosuvastatin 5 to 10 milligrams, or change the statin. For example, we have fluvastatin, which is available as less call 40 or 80 mg. You can use one of those strategies. Let us say even that if a patient is not tolerating, we have to go for ezetimibe. That is cheap in our country, but PCSK inhibitors are quite expensive. For example, evolocumab could be around 16,000 per injection twice a week, so it's quite expensive. And inclisiran is actually 90,000 to 1.2 lakhs every 6 months. So for a given patient who is, it is possible for him to afford, then maybe we can give, because that gives an excellent response to LDL. It is available, but depends on whom we can do. I have not been fortunate to give to any patient because they could not afford. But there are colleagues of mine who have freely used it. Dr. Nasli Ichaparia is one who is from Pune. brilliant neurologist, a teacher for all of us. He has used a lot of patients. There is one Dr. Prachet from Coimbatore. He has used. So a lot of people who have used it. I didn't have the fortunes. I never used any of these molecules.
I
we
think
use.
we neurologists are somewhat conservative, and cardiologists use quite a lot PCSK inhibitors. And now in India, still it's not available, but inclisiran is being extensively used in the West.
Yes,
So these are the two which are like once in 6 months, if you calculate the cost of taking daily plus, if not tolerating well, and the protection which it gives is maybe worth, or if it is insurance supported, it will be worthwhile giving these agents.
Thank you. We usually give in patients, as you said, we want to give the statin as much as possible as it tolerates. So one of the things practically I have used is ask them to take quinine if they get these cramps. Quinine, and particularly in tonic water, it's excellent way of protecting the cramps for them, the symptom. And also some people advise aspirin to be taken along with the statins, and that's supposed to help. I don't know. There's no evidence for that. But practically, I've seen quinine helping a lot of my patients for the cramps. But as you said, if it is still not tolerating, obviously, we have to switch to something else. But changing one statin to another, does it help? Because we know that by studies, almost all of the statins have been shown to be helpful, one or superior to the other. But if you change it to something else, does it help?
Because atorvastatin and things like that are lipid soluble, whereas rosuvastatin and fluvastatin are water soluble.
Yeah.
Some people find more comfort with the other two agents. And we always extrapolate from the cardiological data, for example, from the corona study of those people or from the Jupiter data. We try to extrapolate and try to use it. As of now, the best recommendation is for atorvastatin 18 mg sparkle data. But we do use 40 mg. My personal favorite is always rosuvastatin 40 mg.
Thank you.
Because patients believe that the lesser the number, more safe you are, the doctor you are. 500 mg of paracetamol is more powerful than 50 mg of diclofenac. That is in the mindset of patients.
Do we have questions from the audience? Any question, Dr. Amit, any question from the audience?
No, sir. Currently, there are no questions.
Can I ask one more question, sir?
Please.
Okay. Now, one question regarding, again, the dose use of statins. If the patient has got normal cholesterol levels, the LDL, HDL, triglycerides, all those, and the patient had a lacunar stroke, there is no atherosclerotic changes in the large arteries, would you give statin? I see a lot of them giving statin.
Yeah, we'll have to scan for ICAD and vessel volume aging. And if ICAD is significant, best medical management we have to give. If it contains intensive lipid-lowering agent, along with the aspirin and clopidogrel, maybe for a longer period than what we use in large vessel occlusive disease. And in those cases, at least for 6 months, it may be required rather than 21 days and 3 months. And what Meenakshi mentioned about the clopidogrel, we don't have aspirin 81 milligram in India. We don't have baby aspirin here. We have smaller than the baby, that is 75 milligram. You have 81, we have 75. So smaller baby we have. And we use that. And I prefer clopidogrel if there are multiple risk factors, and in particular, if there is diabetes associated. Because diabetes will also have a lot of arteriosclerosis and lipohydinosis. So in those situations, clopidogrel may be a better choice than aspirin alone as SAPT.
Okay. And the low dose, as you know, by the Scandinavian trial, they gave even the lower dose, 50 milligrams.
35 milligrams. 35. Yeah.
So it is beneficial, they say, yeah.
Actually, they tried from 35 milligram to 1300 milligrams.
Milligrams, yeah.
Swedish study, 1300 milligrams. Then they came out that probably 325 milligram is good. cardiologists use 150 milligram, but while I'm sure most of our neurologists, even SMS, we use 75 milligram aspirin. So many of the combination in India available are 75, 75, 20, 75, 75, 10.
Okay.
So aspirin, clopidogrel, and rosuvastatin respectively, the dosage which I mentioned. So that's what is available in our country.
Thank you.
That's what the
Yeah.
patient was on, sir.
Yeah.
Exactly.
Yeah.
So I think we will,
yeah.
so the panel discussion obviously won't be possible. So I think, and we are also close to our time. If there are any questions, we can discuss. If there are no more, then.
But Amit, there had been panel discussion. Our respected guest from USA joined. He's a panelist.
Yes, sir. Yes, I mean this.
And-
Yes, sorry, I didn't. I meant that. For the topics which we had decided, but
yeah,
this was
that was connected place. You can, if there are some questions, you can even have.
yes.
But time, I think we should respect the time.
Yes, sir. So this is why. But this was very helpful for all our participants and the way SMS sir presented the case, and this is a very different way of normally we have all these didactic presentation, but this was I think very helpful. I'm sure this would have benefited all our participants a lot. So I will thank all of our speakers, Dr. SMS sir, you sir, and Dr. Chidambaram sir, who graciously agreed to join for the discussion. So thank you very much. Till we meet again online.
Amit sir, sorry to interrupt. I think Dr. Kameshwar Prasad sir has just joined.
Oh, okay.
Yeah, good evening to everyone. I was at the airport, so still in the car, but I'm happy to join. Please carry on as your program.
Yeah. Yes, sir. So actually, we are at the end of the program. We had a discussion. I mean, it was not about NXT, but we had discussion about the prevention, and we were waiting. Actually, I did mention that sir has got delayed. Flight has been delayed, and
Yeah. No problem. You can conclude if you want. No, you can conclude.
maybe next time, sir, we will plan another meeting, and then
we miss you, Professor Kameshwar, and we had good discussion. And Meenakshi presented very good case vignette, and it was case vignette oriented risk factors and their management. So
very good, very good.
Next time we'll have some this panel discussion while in the air.
Right. Good.
Namaste, sir.
Yeah.
Sir, namaste, sir.
Namaste. Sorry, I was in flight, so I could not have joined. So
We missed you, sir.
Yeah.
and we had sir, Professor Chidambaram sir had mentioned your book also.
Acha. Some people like it. That's good.
Sir, we have with us Dr. Chidambaram Megappan. He's a faculty at McMaster University, Canada. So he joined us. He's from our place. And yesterday he took a class for us in Madurai. So I invited him to join us. So he's in one of the panelists there today, sir. Dr. Mendrita sir was graceful enough to take him to the panel as well.
Very good. McMaster is my,
Alma mater.
institution. Alma mater, yes, alma mater. Yes. Because I did master's degree there, so I always remember, and we have good friends there. So good to meet you, and let's keep in touch.
Yes, sir. Yes. When you were there, I think there was no stroke unit at McMaster, but now there is a stroke unit, stroke division, etc. As you written the book, my residents used to show me and buy it in the store and show me. I saw that your name regarding evidence base. Yes.
Yes. Book is more popular in now.
Good, sir. Nice to know you.
Good to see you. Good to meet you also. So please, Dr. Mendrita, please feel free to conclude.
Yeah. Yeah, I think we had very good discussion, and in the end, we were fortunate that Dr. Kameshwar could also join. And I think we'll have maybe some more session later, fully devoted to Tenacti Place and discussion about the now concentration on tissue rather than the time,
Yes.
and extended window like rather than they say hours. I always say minutes, 180 minutes or 270 minutes. It's like ISRO satellite or NASA satellite being launched. So reverse counting. So same way now people are paying more attention on tissue from 4.5 to 24 hours. And in the recent guidelines, there are mentioned, ISO guideline does mention. Now there's a new study which will be perfusion based, either CT or MR perfusion based, which will decide the salvageable tissue in the core or in the penumbra, and to extend the window like it has been extended in from 3 to 4.5 hours for thrombolysis and extended window for mechanical thrombectomy. Similar way, we are likely to have extended window for thrombolysis in the coming months or years, or in the near future, I would say. Yeah, that was I wanted to convey. And from my side, thank you so much. And if you wish, we can conclude.
Okay.
Okay, thank you very much for
Thank you
the
very much.
encouragement, sir.
Thank you.
Thank
very
you
much,
for
sir.
inviting me. Thank you.
Thank you, sir.
Thanks, everyone. Thanks, everyone.
Thank you. Thank you, sir.
Thank you,
Okay,
sir.
okay, Dr. Kameshwar. Bye-bye.
Thank you, sir.
Bye-bye.
Bye.
Thank you so much. Thank you, everyone.
Thank you, Kalpita madam. Madam,
Thank
please
you.
remember to give the prize to the person who got this
Yes,
one.
yes. I think it is Dr. Chidambaram only. He has answered majority of the
Madam,
questions.
you cannot give prize to him. You can give to the faculty.
Whatever the prize he has got, he should donate to the government of India. Yeah.
Yes, sir.
Or Madurai Medical College. Yeah.
Yes.
Sir, once again, thank you very much for the encouragement, sir.
Okay, dear. All the best.
Nice to be blessed by you, sir.
No, my privilege indeed.
Thank you
Thank
so
you,
much.
sir.
Thank you.
Thank you very much. Thank you,
Can
Kalpita madam. Thank you.
we log off?
And
Sure.
please convey my thanks to Dr. Mehta also, Dr. Supriya Mehta.